Good afternoon and welcome again everyone. On behalf of the WBMT Nurses Group, in collaboration with your institution, the Lagos University Teaching Hospital and the Sickle Cell Foundation, Nigeria, I would like to thank you all for participating in this fourth webinar for the BMT nurses. Today we are honored by our invited speakers who will share with us very relevant topics to further our knowledge and insights related to BMT patient care, as well as the fundamentals of internal policies and procedures. May I inform everyone that for this webinar session, we will be diverting from the usual format. We will have 5-minute question and answer right away, right after every topic that will be moderated by Amina and myself. We encourage everyone to write down your question in the question answer module of the Zoom, or you may raise your hand and the moderator will take your question. You may also ask follow-up questions at the end of the last topic. In case your question cannot be answered due to the absence of the actual speaker, you may send it to Blessing or email it to Mr. Rommel, whose email address can be found in the flyer. We will refer it to the lecturer and will try our best to send out the answer to all the participants. In addition, and most importantly, we will be sending out an evaluation form to your email addresses. It is important that you fill it in so that the committee can do a study and determine how to improve more the webinar to render optimal help to all of you. We will now proceed with the presentations, and it is indeed a pleasure for me to introduce our first nurse expert lecturer. Our first speaker is Paola Viveros Lamas from Chile, and one of our active WBMT Nurse Group Committee officers, and was our previous moderator of last month's webinar. A nurse by profession from the University of Chile, she obtained her training in hematopoietic stem cell transplant in Curitiba, Brazil. She is certified in pediatric hemato-oncology by the Oncology Nursing Certification Corporation. She is currently a coordinator, contractor of St. Jude Global Nursing Projects for Latin America. I'm privileged to welcome Paola, who will be presenting to us the topic on the management of the central venous catheter, or CVC. Over to Paola.
This presentation is about the care and maintenance of central venous catheters. The aim is to give an overview of the catheters and provide recommendation on their care. In this presentation, we will review the following points: an overview of central venous catheters, use of this device, central venous catheters used in stem cell transplant, and finally, some recommended of care in use and maintenance of central venous catheters. Central venous catheters, also known as central lines, are medical devices used to access the large veins in the body, and these kind of devices are surgically inserted through the skin into the subclavian or internal jugular vein, with the tip located at the junction of the vena cava and the right atrium. As we know, central line is a very important tool in the stem cell transplant process because we use this line for the infusion of the stem cell and all medication that patients need as supportive treatment. The installation of this kind of the catheter is an elective surgery indicated by a doctor and performed in an operating room by a trained surgeon. The procedure is performed using aseptic technique to minimize the risk of infection, and the verification of catheter placement is performed using a chest X-ray to ensure proper position. To reduce this risk associated with the installation of long-term central line, patient must meet certain conditions, such as being in a good general condition. They should not be suffering from an infection condition, and they should not have a coagulation disorder. Also, patient must have an absolute neutrophil count greater than 500 and a platelet count of at least 50,000 per cubic milliliter. As I told you, central lines are widely used in patients who need long-term treatment because we can use this device to give various intravenous solution and medication. For example, in transplant patients, the catheters are used to administer chemotherapy, stem cell, parenteral nutrition, medication, and blood, among other solutions. They can also be used to take laboratory sample and also for measure central venous pressure. Long-term central venous catheter can be either tunneled external catheters or implantable catheters. In this slide, you can see some brands of this type of catheters, including Broviac, Hickman, and Grosjean for tunneled catheters, and Portacat's Mediport or Chemoport for implantable catheters. Tunnel external central line are the most used in transplant process, especially because it allows the flow of the stem cell directly into the blood circulation without the risk of them getting trapped somewhere in the infusion set. These catheters are inserted using a tunneling technique with a subcutaneous route where the distal end is externalized at the upper thoracic arm or another level. They are made of radiopaque silicone, polyethylene, or polypropylene. These devices have clamps that are located in the protective sleeve and have lower connection. They can have 1, 2, or 3 lumens of different calibers, and if you have, for example, more than 1 lumen, these are independent of each other, so allowing you to infuse solution in parallel regardless of compatibility. Despite being very useful for patients who need multiple therapies, its use can unfortunately be associated with complications such as infection, occlusion, among others. So, proper care and maintenance are crucial to minimize this risk. Now we are going to review some recommended care to prevent complication. First, the catheter evaluation. Assess the exit site and surrounding area by palpation and inspection, looking for signs of complication. Some signs could be found are edema, pain, skin lesion, for example. About the permeability, later we are going to review more detail about the permeability. It's very important to check this point. Measure the length of the catheter at each exit site cleaning, from the exit site to predetermined site. This allows detecting if there is displacement of the catheter. If there is a difference of more than 2 centimeters between control, it is very important to notify the doctor to check the location with an X-ray. This evaluation should be done daily and during each shift. In relation to the care of the exit site, a sterile, transparent, semi-permeable dressing is recommended to protect the sites. This type of pads allow visual inspection of the exit site, provides support, and keeps the surround skin dry. The semi-permeable transparent dressing to be replaced every 7 days or whenever it becomes dirty, wet, or lose its integrity. But if it is protected with a gauze dressing, it must be changed every 48 hours. As in all procedures with central line, hand washing is essential to prevent infection. So, the dressing chain has a clean face where we remove the old dressing. We can do it without gloves, with clean hands. And then a sterile face where we wash our hand again, and with sterile gloves, we clean the exit site and put the new one dressing. To clean and disinfect the skin during dressing change, first use saline solution to clean the skin, and then disinfect, preferably with alcohol-based chlorhexidine. And if there is a contraindication, for example, for chlorhexidine, you can use povidone iodine or 70% alcohol. You must use aseptic technique in this procedure. If it's possible, use a sterile single-use applicator and avoid multi-dose antiseptic bottle. And allow the antiseptic to dry according to manufacturer recommended time. 15 seconds for 17% alcohol, 30 to 60 seconds for alcohol-based chlorhexidine, and 3 minutes for povidone iodine. About the infusion set, one of the most important measures to prevent the entry of pathogens into the blood through the catheter is the cleaning and disinfection of the infusion set every time it is going to be opened. It's very important performing mechanical cleaning with friction to disinfect the connector before its access. The recommendation is rubbing for at least 15 seconds. The most used disinfection solutions are 70% alcohol and alcoholic chlorhexidine solution. And it is also important to use the non-touch technique when accessing or changing connectors, which means not contaminating the catheter entry points. In relation to frequency of changing the infusion set, the recommendation is to change the infusion set every 96 hours, except when you are infusing fluids such as parenteral nutrition or lipids. In that case, the set must be changed every 24 hours. And if you are infusing red blood cells, you have to remove the set immediately when the infusion ends. Or when you can see their precipitates or visible blood, you have to change immediately. Occlusion of the central line is one of the most frequent complications, which is why practice to maintain the patency of the line are very, very important. First, keep in mind that the key moments in which the central line must be flushed, you have to keep in mind. have to flush and aspirate the catheter before each infusion, flush after each infusion, and close after completing the last infusion. If you are not using the catheter, the tunnel catheter, it should be flushed once a week. For this, you have to use syringes of at least 10 milliliters to control injection pressure. It's very important to prefer the pulse technique to flush. This practice has been shown to be effective in removing fibrin, precipitated medication, and bacteria. Pulse flush technique means taking short pause after each milliliter of saline infusion. You have to push to solution and then stop. Push, stop, push, stop. Another important point is to block the catheter with the positive pressure to prevent blood reflux. This means that you have to close the clamp while the last milliliter of saline are being infused. For central line flushing, you should consider 1. Flush with at least 10 milliliters of normal saline after infusing medication or solution, and with at least 20 milliliters after blood collection, administration of parenteral nutrition, blood products, or the use, for example, the contrasted medium. If medication incompatible with normal saline have been administered, flush first with the 5% dextrose and then with the normal saline, but never you have to leave dextrose in the central line. Another measure to ensure the patency of the central line is to maintain the infusion of solution at an infusion rate of no less than 10 milliliters per hour, and always use, if you can, use infusion pumps. Finally, a fundamental aspect for the prevention of complications related to the central venous catheter is the training of the team involved in any process of using this device. Carrying out periodic evaluation of knowledge and compliance with the protocol are highly recommended practice. And don't not forget that the care and maintenance of central venous catheter should only be carried out by properly trained personnel. And let's keep in mind that learning is not the product of the teaching. Learning is the product of the activity of learner. Thank you so much for your attention.
Thank you, Paola. Thank you for your presentation. It was very relevant, and you have included many practical aspects. Thank you. So, is there any questions?
I can see 2 questions in the chat. In the chat of us, Carol asking us about if it is necessary when you flushing once a week, when not in use, do you have to withdraw 10 ml before flushing? It is not our practice, Carol. We don't remove maybe you try if the catheter is refluid, but not eliminate 10 ml of blood, because we work with pediatric patients, so 10 ml is too much blood for them. So maybe you can eliminate, for example, if you are taking sample of exam, you eliminate between 3 and 5 ml of blood. So you can do
the same practice for clean, but it's not necessary. You just have to prove if a catheter is refluid, and after that you have to flush. You can use just saline normal solution, or in another institution, they are using heparin yet. But in another institution, they don't use more heparin solution. I don't know if ask.
Yeah,
Okay.
yeah, that's right. So even sometimes the patients may come for investigations. So if they come for investigations, we can take a sample and flush the line. That is also possible. And then same time, the dressing also can be changed. So that's what we do in our institution. So that is also, it is possible.
Perfect.
Okay.
Thank you, Amala. Thank you, Carol.
Thank you. I think there is one more question. I think one more question I'll just look into. What is the duration of stay of central line set for a patient? Duration of stay of central line set for a patient. So this is the question. Paola, you would like to respond?
Yes. Thank you, Amala. So I just to clarify if means the set of the infusion, that is Blessing.
I think that she meant the catheter, central line catheter, CVC.
Perfect. Blessing is she has the hand raising. You have to you want to talk about this or another thing?
No, we have questions from the on-site participants, about 5 questions here.
Okay. So about the set of the infusion, we keep during 4 days if you are give some all solution, except if you have, for example, no parenteral nutrition, blood, because they need more frequently changed. But of the rest of the solution, you can keep the same set infusion for 4 days, 96 hours.
Okay. There is 2 more questions. Yeah, this we answered. How often do you change dressing for central line? How often the dressing to be changed?
Yes, that depends of the kind of the dressing, because if you have only, for example, only sterile gauze, you have to change every 2 days, every 48 hours or 2 days. But if you have the semi-permeable dressing, sterile dressing, and transparent dressing, the ideally dressing, you can change every 7 days, once a week.
Yeah, that's right, Paula. And maybe when the catheter is inserted, they may have bleeding from the insertion site. So at that time, we may use gauze dressing. So that should be changed after 48 hours. But once changed to transparent dressing, it can be changed once a week. Also, you mentioned whenever the dressing becomes very dirty, wet, it can be changed even before 1 week. Thank you.
Yes, you are right. Yes.
The first question here is, someone is asking, when you're taking care of the central line, should you flush before aspirating, or do you aspirate before flushing the line in case there is a blood clot?
Yes, I have a video I want to share with you later, but the first we aspirate because we have to check return of the blood, and after that we flush with saline, normal saline. But if you are aspirating and you don't have a reflux of the blood, you can ask a patient, or you can ask the patient to move, for example, head or arm. We move the patient and aspirate again, and if you have reflux, you can give the flush with saline, normal saline. The first aspiration, and after
Okay.
that, flush.
Okay.
Yeah.
Thank you. So
So
the
this
next
is
question
very
is,
essential, Blessing. This is very
yes, ma'am.
essential to make sure the catheter is inside the blood vessel. So that is why we need to
Okay.
look for the backflow of blood. So aspirate and
Oh.
check, and then catheter must be flushed. Thank you. Okay.
Thank you, ma'am. Okay, so
Yes.
the next question is, when flushing the line, you mentioned that the line should be flushed with 10 mils of saline if medication has been given, and 20 mils of saline if blood samples have been taken. So when flushing the line, if you find a blood clot within the line, do you flush still or aspirate?
Eliminate, and you can flush with more saline solution, because if you have a clot, sorry, you are talking about the occlusion catheter, or you can found the clot?
Yes, a clot, like small clots within the line.
In the line.
Yeah, okay. If you have a clot, you can retire the clot. You can use the catheter in normal way. But if you cannot,
Remove.
flash, you have to, you can use some medication under medical supervision. For example, and I don't know how do you say in English, antifibronolítico, ¿tú cachai, Katy?
Yes.
¿Cómo se dice en inglés?
That's right.
Sorry, but I don't know how do you say in English, but you
Yeah.
have some medication that you can use, for example, in the Eugenia. Thank you.
Mm.
Yeah, is that we use is some antifibrinolytic, and we have
Yes.
the urokinase. That is, I think, is the
Yes.
same name. That is a special dilution. You have 5,000 units for 1 milliliters, or if the clot is very, very big, and that is in the high level and with the physician supervision. That is the Alta Plus.
Mm.
That is the both what we did. But the second one, the Alta Plus, should be with the order. Yes, it should be with the physician. Is the let me write here. Here I am going to write here is the
Blessing, the important, sorry.
Yeah, Paola and Eugenia, this is a very important question, and there is a guidelines about it. So when there is a clot, it's under medical supervision. We have to give antifibro. So we have this policy. So maybe we shall send it to them as material. Please, Eugenia, this is very important.
So I will check. I will share with them the political that we have for this with the urokinase or with Alta Plus. Okay.
Yes, so this is.
I will share with them.
This is international. It's what we are
Yes.
giving all over. Yes, thank you very
Number
much.
indications.
Yes, I want to clarify something because for our experience, Blessing, many times the occlusion is not for clots. Maybe the catheter is
Positioning.
the position. Yes, you
Yes.
can try another things before use this kind of the medication. You can ask, for example, to patient move, change of the position. You can use, for example, the push stop technique with just saline, normal saline solution. You don't use never syringes less 10 milliliters because you up or increase the pressure could be damage for patients. So do you can, for example, with the syringes with saline solution, as patient move, during the moving, you can do can flash stop. It is enough to recover the permeability. So the clots for use this kind of medication is very less frequent. It's not frequent.
Okay. All right. I do understand now. Okay, so another question here is can the tunnel Hickman line be used for exchange blood transfusion? Yes, can the tunnel Hickman line be used for exchange blood transfusion?
Yes, we can use. You can use this kind of catheter for transfusion. You have to take sure that have parallel to blood product a saline solution to parallel for help the permeability, but you can use this kind catheter for transfusion. And after transfusion, you have to flush with 20 milliliters of saline solution.
Sorry, again, it's me. Paola, Blazing, I think you are talking about apheresis, stem cell apheresis, right?
Yes, ma'am.
Yes. So the Hickman line, I don't think it cannot be used for stem cell apheresis. We have to have a permacat. And Paola, you can show it. We have some picture to show the difference between permacat and Hickman line. It will be very helpful for you guys. In your video, maybe you have it, Paola, because here there are,
no,
you don't
not really.
Because when you go under the machine, the permacat, the Hickman, the line has to be very hard because otherwise it will stuck. It will not, they will not be able to get the stem cell out of the machine. You know what I mean? So we need to have a special catheter when you do stem cell apheresis. I may
yes,
yeah.
I understand, but I not really knows the permacat, but we can find information about it. We with Eugenia we talk with another friend that she's very expert in apheresis. So later we are going to prepare this information for Blessing and the team.
please,
Mhm.
because you know all these sickle cells, they need to have stem cell management before transplant, so we need to provide this material to them. Thank you.
Can I just make a comment?
Yes.
Yes.
You could utilize your Hickman line in an apheresis situation as your return, so that you can take blood from a vein, but also return into the Hickman line.
You're right. Yes, this for the return, but when you aspirate, you can't because it's blocked. Yes, you're right. You're right. But we can provide all this material to them.
Yes.
Blessing, please, with Paola, Eugenia, we will send you all this.
In my presentation, there are some information about the apheresis, about the different ways that you can find the information. But anyway, we, Paola and myself, we will provide you with all the information that you need.
Thank you. Yes.
All right.
All right.
So the last question, how long does the pain last after the line insertion? Like, how many days does the patient feel the line? Does the patient feel pain and discomfort after insertion of the line? Is there a duration to it? And what advice can we give to the patient whose line has just been inserted and is having pain on the site of insertion? How long after the insertion would the patient feel pain? So a patient whose line has just been inserted, what's the duration from the time of insertion of the line and when the pain will significantly reduce? How long does it take, and what advice can we give to the patient to help with the pain management from the site of insertion?
Depend
yes.
of the surgery, because sometimes in some patient, for example, if patient is most fat, they have more tissues, so sometimes the surgery is more hard. If the surgery is more hard, more manipulation, the pain is longer than, for example, if the surgery is more easy. For our experience, the pain, the duration of the pain is 1-2 days, no more than that.
Is it normal after the line insertion that the patient feels pain while trying to lift hands and carry out range of motion with the hand on the site, with the hand on the same site of insertion?
Can I just add a point to that?
Yeah.
Maybe this pain will be
Okay.
very short period, and sometimes we encourage our patients that ball exercises. Ball exercise also we'll ask them to do it. So that also will help in relieving pain.
Okay. So small exercises.
Yeah, small exercise. Soft ball. They can have the soft ball in their hand. They can squeeze it, and then so that also will help in reducing pain.
Yes.
So all these lines, including the PICC lines, that is peripherally inserted central venous catheter, all the lines are done by the doctors in the theater, or who does the line in your place?
It's done by the cardiothoracic surgeon in the theater.
Surgeon in the theater. Okay. Okay, so our second speaker is Catherine, and she was born in New York, USA, and attended her college in Santiago, Chile, where she resides with her beautiful 2 children. And she is a passionate registered nurse who has been specializing in pediatric and children's oncology for the past 17 years. She has been recognized at work and her alma mater, Universidad de Los Andes, for her leadership in this field, constant support and inspiration to new nurses by sharing best practices and, more importantly, her experience. Currently, she is a nurse coordinator in bone marrow transplant unit at Pontificia Universidad Católica de Chile. Likewise, Catherine joins us through a recorded presentation due to the time zone difference. It is indeed a privilege to welcome our guest speaker who will discuss to us on interesting topic on 100 days post HSCT or BMT. Over to Catherine.
Hi, my name is Catherine Gutierrez. I'm a nurse coordinator from the Bone Marrow Transplant Unit at Hospital Clínico Universidad Católica in Chile. Today, I'm going to talk about the main milestones that occur at 100 days post-bone marrow transplant. Stem cell transplantation is a therapeutic option for several malignant diseases, like leukemia, and non-malignant disease, like severe aplastic anemia. When we refer to 100 days post-transplant, we're talking about where the patient's recovery is closely monitored for complications and progress. The progress has to include physical and psychosocial aspects. At this point, the new bone marrow begins to produce blood cells and the immune system starts to recover. A little bit of overview of the bone marrow transplantation. We know that it is a procedure in which a patient receives healthy stem cells to replace their own stem cells that have been destroyed by radiation, high doses of chemotherapy, or both. We have three types of bone marrow transplant. The first one is the autologous, where the cells come from the own patient and we collect them and save them before the treatment. We have the allogenic transplant, that the cells come from a related donor or an unrelated donor. And finally, we have the syngeneic, and the cells come from an identical twin. We know that the stem cells are capable of repopulating all the hematopoietic and lymphocytic population, while they maintain the capacity for self-regeneration. That way, they can assure a long-term immunologic and hematopoietic viability. We have three sources where we can obtain stem cells. The first one is bone marrow, which is harvested from the iliac bone under general anesthesia. We have the peripheral blood stem cells, also known as PBSC, and includes mobilization of the stem cells to the peripheral blood. Finally, we have the umbilical cord blood, which is collected right after birth. The choice depends on the accessibility of the donor, the disease, and the urgency for the transplant. The indication for a bone marrow transplant depends on numerous factors, such as the disease type, the stage, and response to previous treatment. We can see here some of the indications for adult and pediatric patients. For example, an autologous transplant is indicated in patients adults with multiple myeloma, lymphomas, and some germ cell tumors. In the pediatric population, it's indicated in high-risk neuroblastoma. The allogenic transplant is indicated in adults with leukemia, myelofibrosis, relapsed lymphomas after a bone marrow transplant, and also severe aplastic anemia. Pediatric patients also have the recommendation of an allogenic transplant in leukemias, severe aplastic anemia, and inborn errors of immunity like the SCID, non-inborn errors of immunity like Wiskott-Aldrich syndrome, and inherited bone marrow failure like Fanconi anemia. We have seen today that there's a lot of evidence for autologous transplant in adults for some disease like multiple sclerosis and Crohn's disease. Here we have the timeline for a bone marrow transplant process. Depending on the type of transplant, we might need to harvest the cells first and cryopreserve them. When we start conditioning the patient, we are looking to eradicate the disease, create some space for the donor stem cells to engraft, and immunosuppression to decrease the risk of rejection of the cells by the host. This therapy can be only chemotherapy or chemotherapy and radiation. At day 0, we infuse the cells from the donor into the patient. From day 0 until day 15 approximately, we have the state of aplasia, where there's no production of white blood cells, red cells, or platelets. When engraftment occurs, the cells are being produced thanks to the new stem cells. After bone marrow transplant, we can have 2 phases. First, the initial recovery from day 0 until day 30, and the early recovery from day 30 until day 100. In the initial phase, our patient is going to be in a hospital setting. We will have to treat different complications, infections, supportive care like transfusion and pain management, monitor daily for blood counts so we can see when engraftment occurs. In the early phase, the patient is going to be discharged and transition to an outpatient care, where we're going to continue to monitor for engraftment, management of the immunosuppressive therapy, infections, and graft versus host disease. What are the aspects of the 100 days milestone? Engraftment and blood counts, immune system recovery, graft versus host disease, medication, physical and emotional recovery, and follow-up care. We're going to review them in detail. The first aspect is engraftment. When we talk about engraftment, the goal is to achieve a sustained engraftment, and it is defined as neutrophil and platelet recovery after the aplasia period. Neutrophil recovery is defined as an absolute neutrophil count higher than 500 for the first 3 consecutive daily measurements, and platelet is defined as a platelet count higher than 20,000. There are some factors that influence engraftment. Like we mentioned before, we have different sources to obtain stem cells. We can see that engraftment occurs earlier with cells from PBSC than bone marrow. Also, the immune function recovers first, and this is likely due to the higher number of mature cells. We do need a minimum dose of stem cells, and the minimum is 2.5 million of cells per kilogram. Graft manipulation can also affect the engraftment, and this can happen when we have to do a cryopreservation or manipulate the graft to reduce the blood cells. What cases we might need to do that? When we have an ABO incompatibility. The microenvironment of the host is also a factor, and this is due to the damage caused with the previous treatment and the conditioning, that it can hinder the hematopoietic recovery. Also, graft versus host disease, it can be a factor that influences engraftment because of the immunosuppression that we use for prophylaxis may affect the hematopoietic recovery. In this table, we can see the difference of time of engraftment depending on the source of the cells. And cells, like we mentioned before, that come from PBSC are more likely to engraft earlier than cells from another source. How we can know that engraftment is occurring? The patient is going to have fever, joint and muscle ache, malaise, and erythema. Because these symptoms are very similar to an infection, we must rule out a differential diagnosis and make sure that it's not an infectious process going on. Shortly after the engraftment becomes evident in the bloodstream, we will see in the blood work a rise in the white blood count and a measurable absolute neutrophil count. The platelets are also going to rise. Our patient's going to start to feel better. Mucositis begins to improve and resolve, and the need for transfusions is also going to decrease. At this time, patients may develop acute graft versus host disease as early as the initial engraftment. The second aspect of the 100-day milestone is the immune system recovery. Patients lose their immune memory of a lifetime exposure to infectious agents, environmental antigens, and vaccines. The patient should be revaccinated once T and B cell immunity has sufficiently recovered, and that usually occurs at 6 months post bone marrow transplant. We do recommend family members to continue to have all the routine vaccines. That way we can avoid infection transmission to the patient. In this figure, we can see how the immune system starts to recover after a bone marrow transplant. So right after the neutropenia period, the immune reconstitution is very slowly. So that is why around month 6 after the transplant, vaccines are recommended. This figure is showing us the ideal scenario without any complications. For example, if the patient has an infection, the immune reconstitution might be delayed. Patients are at great risk for infection during the neutropenia period and even after the bone marrow transplant due to the immune system that needs to recover. It is the cause of mortality and morbidity in stem cell transplantation due to the toxicity of the conditioning and treatment that patient has received before. We can have viral infections. Most frequent is the cytomegalovirus, Epstein-Barr, some bacterial infections, and fungal infections. Improvements over the past couple of decades have been made, especially in supportive care, and have helped to reduce the risk of infection and complications for our patients. If we have a prolonged period of neutropenia, it increases the risk for bacterial infections, but also the lack of immunity can increase the risk of infection. The immune reconstitution takes place broadly in 3 phases. The first one is the pre-engraftment, where we have a prolonged neutropenia, we have the presence of a central line, and also the breakdown of the mucosa barrier. Here we can see the most common bacteria, viral, and fungal infections that the patient can present in this period. Phase 2 is the post-engraftment. We have some cellular immunity, but it can be impacted by the use of the immune suppressive therapy that we need to prevent graft versus host disease. In phase 3, we can have some humoral immunity, and as the days after the transplant progress, the risk of infection decreases, but does not disappear. The third aspect in the 100-day milestone is the graft versus host disease. It occurs when the T cells from the donor recognizes and damage the tissue in the immunocompromised recipient. It can be a potentially serious complication, and it's a major cause of morbidity and mortality after allogenic stem cell transplant. Unfortunately, it affects approximately 30 to 40% of the recipients. Graft versus host disease is a cell-mediated reaction of the donor against the recipient tissue. It requires the presence of the immune-competent cells from the donor, the inability of the recipient to reject the donor cells, and the need of the recipient to express tissue antigens that are not present in the donor. This figure shows us the 3 phases of the process for the acute graft versus host disease. The first one, we have the initial host tissue that is damaged from the conditioning therapy. The recipient cells will secrete inflammatory cytokines. In the second phase, the donor T cells will activate, and in phase 3, we will have cellular and inflammatory effectors. What are the risk factors to present graft versus host disease? To have an older recipient and donor, sex mismatch, and specifically female donor into a male donor. The conditioning regimen, because we have a greater tissue damage, more inflammation from the alloreactive cells, and high doses of radiation. Graft versus host disease can be divided into acute and chronic. Acute can happen in the first 100 days after the transplant, and it can affect three main tissues: the skin, the liver, and the gastrointestinal tract. Chronic graft versus host disease can happen after 100 days, and the manifestations may be limited to one single organ or site, or they can be widespread. This can have a profound impact on the quality of life in the patient, because chronic graft versus host disease can last for years or a lifetime and can affect the self-esteem of our patient. That is why it's so important for the nurses to know the signs and symptoms so we can teach the patients to identify them. In this table, we can see signs and symptoms of acute graft versus host disease. The first organ affected, the skin. We can see a rash that is flat and red and usually starts in the hands, feet, or around the ears, also in the upper chest. The rash can spread and cover the entire body, and sometimes it can be a little bit itchy or even sore. Patients refer it as the sensation of a sunburn. For the gastrointestinal tract, we can have patients with diarrhea, and it's important for them to tell us the amount, if it has any kind of secretions or blood. We can also have a patient with weight loss, stomach discomfort and pain, nausea, and vomiting. And in the liver, usually we don't see any symptoms, but we see in the blood work the liver enzymes that are elevated. Here we have two pictures of acute graft versus host disease affecting the skin. This patient is started in the hands and around the ears, as you can see here, and it did spread to cover the upper body. He did refer the sensation of a sunburn, so he had to be admitted to the hospital to receive the proper treatment. Here we have a table where we can see the signs and symptoms of the chronic graft versus host disease that occurs after day 100, and it can affect one organ or more than one. In the eyes, we can see patients with dry eyes and sometimes with blurred vision. The mouth, dry mouth as well, sensitivity to things that are hot, cold, and sometimes mint, difficulty eating, and some mouth sores that are painful. In the skin, we can continue with the rash that started in an acute moment, but now the skin feels more dry, tight, itchy, and has a change of color. Nails, we can have a change in the texture and nail loss. Here we have more organs that can be affected. Gastrointestinal, we can see a patient with loss of appetite, weight loss, nausea, vomiting, and some stomach pain. The lungs can also be affected. We can see patients with shortness of breath or persistent cough. In the liver, we can see abdominal swelling and liver enzymes continue to be elevated. And now we can see some signs like jaundice. Muscle and joints can also be affected. We can have patients with muscle weakness and joint stiffness, which can difficult the extending of the wrist and the elbows. And genitals can also be affected. Patients can have vaginal dryness or irritation of the penis. Here you can see the photographic range of motion. This is a tool that's going to help us to stage the chronic graft versus host disease that can affect muscles and joints. we ask the patient to do those movements and see if he's able to fully extend the joint. We're going to assign a number, and then we're going to be able to define what grade of chronic graft versus host disease the patient has. When we have a patient with graft versus host disease, we need to diagnose it with all the signs and symptoms that we saw and to stage it. Also, we have to rule out that it's not an infection or a drug reaction that can give us similar symptoms like the graft versus host disease. These days, we have some help, and recently it was designed an electronic tool by the BMT and the National Institute of Health, and it's an algorithm that will help us apply the criteria to assess the graft versus host disease. It's really easy. It will just ask you to check on the signs and symptoms that the patient has, and then it will give you the grade and the stage the graft versus host disease. Now that we have reviewed signs and symptoms of graft versus host disease, we need to know that prevention is the goal, and how we can do that with prophylaxis medication that is given in the conditioning regimen of the patient. The first line treatment for acute and chronic graft versus host disease are steroids. We do have some recipients that are refractory to the steroids, but they do have options available. There is a second and third line of treatment. Nurses are at the center of the patient's care, and we are in the best position to guide and advise our patients and family throughout this long-term complication. The fourth milestone at the 100 days post-bone marrow transplant is the medication. When our patients are discharged after the bone marrow transplant, they take a lot of medication. They can be on immunosuppressants, steroids if they had graft versus host disease, antiviral medication, antibiotics, and antifungal. At this point, we do start weaning off some medication, especially those to prevent graft versus host disease. At some point, we might be taper off the patient if it's stable. And why we want to take off the immunosuppressant? Because we want the immune system to start to recover. The fifth milestone is the physical and emotional support. But it's not that we apply this only at 100-day post-bone marrow transplant. It's something that we do need to address from the beginning of the process of the patient and the caregiver. Survivors can have the recovery last for several months or even years. And if the process has not been smoothly, they can have poor physical and mental health. We do want our patients to have a good quality of life and to return to their normal routine as soon as possible. Some patients at this point even return to work. This is a figure that shows us that the caregiver also can have social, physical, psychosocial, and spiritual needs. It's a tough job. It's not easy to take care of a patient that has been through the process of a bone marrow transplant. So the last milestone is the follow-up care. This will be different if the transplant is autologous or allogenic. In the autologous transplant, the patient will be discharged, and then the follow-up will continue until day 100, where we do have to do some imaging testing, also specific tumor markers, continue to evaluate the patient support system, start immunizations at 6 months, and control of the baseline disease. In the allogenic transplant, after the patient is discharged and until day 100, we will do at first weekly clinical evaluations, usually during the first month, and then we will do them every other week depending on the evaluation that we see in the patient. We will assess the patient for graft versus host disease, continue to evaluate the patient support system, and at 6 months, it can start the immunization if we have no graft versus host disease going on, and also the control of the baseline disease. Before we finish, I wanted to show you a clinical case. This is a patient from my hospital, a 23-year-old male. He is from Venezuela. He lives in Chile with his mother. He has no children. He was diagnosed with a high-risk ALL. He received induction chemotherapy. We identified an haploidentical donor, his mother. The CVMB status previous was both of them positive. They do share the same blood group. He received his conditioning treatment, and we did the infusion in November last year. We did infuse a good amount of cells. They were from apheresis, and he was discharged at day 35. In the initial recovery, that it was from day 0 until day 30, he did have a viral reactivation. He required treatment until he was tested negative. He received blood transfusion. We did have to treat the pain for mucositis, and engraftment was for the neutrophils at day 15 and platelets at day 12. After he was discharged, he was in an outpatient setting, and at day 45, he had a GI infection. He started with fever, abdominal pain, and C. diff infection was diagnosed. So he was at the hospital for around 10 days. At day 60, he started with a skin acute graft versus host disease in the arms and hands. So he started with steroids. At day 100, we checked his baseline disease, and he was in complete remission. He does continue with graft versus host disease, so he's still under the treatment of steroid. Since he still has the graft versus host disease, he was only allowed to start the flu vaccine, and we will check his blood work in a month, and he's now able to go back to work. As a conclusion, we can see that stem cell transplant is a particular treatment for many hematological and non-hematological disease. We can have different sources of stem cells. The treatment can be divided into the harvest of the stem cells, the conditioning, ablation, and engraftment until the full recovery of the hematopoietic functions. The patients require specific care to overcome physical and emotional problems that result from this long treatment. That is why nurses are essential to start our education before the admission and inform our patient the possible scenario that it's going to happen, and also to evaluate the support system that the patient has. Here is a picture. I wanted to thank you, and here's a picture of my team. We are 3 nurses at the bone marrow unit. Thank you very much.
Catherine, excellent presentation, Catherine. You included all the components of 100 days evaluation when the patient they come, and what are all the different aspects the nurses, the patient has to be evaluated when they come for follow-up. So it is very, very good presentation. So maybe we can invite the audience, any questions if they have, we can take up the questions.
Yes, so we have a question here.
Yes.
So you mentioned in the case, thank you very much. Sorry, I forgot to say for the presentation. It was quite,
Catherine?
it was
Yes, I'm
very,
here.
very insightful. Yeah. So the question is, when should vaccination start post BMT? Because in the case study you gave, you said that it was only flu vaccine that was given at the time because the patients had GVHD. So what are the contraindications to giving the vaccination, and when is the ideal timing?
So the ideal timing is after 6 months of the bone marrow transplant. But you have to consider if the patient has an infection, or in this case, graft versus host disease, because of the medication that he's taking. If he's taking a high dose of the immune suppression and you apply the vaccine, he's not going to have a response to the vaccine. So that's why sometimes you have to delay the start of the process. So why he was allowed, our patient, to have only the flu vaccine is because we are in the winter session right now. So there's a lot of flu going on. So that's why he was only allowed to start with that one. But I can say it depends on the patient, and you have to have all the factors together.
Okay, ma'am. Thank you very much.
Thank you. Catherine, I would like to ask you, what are all the other vaccines do you give for the recipient, apart from the flu vaccine?
So here, our patient has to have all the vaccines that they receive as a child, like hepatitis B, hepatitis A, pneumococcal, and it's a big calendar. Usually it takes 2 years to do all that. It's divided in, let's say, like 3 months, 6 months, and all that. And we do allow patients to do vaccines from live virus after 2 years of the transplant.
Correct. Thank you. We also follow
welcome.
the same regime.
Yeah.
And also, like, as you were saying, Catherine was saying, each patient, the vaccination time may differ. So that is depending on the patient
Right.
complications. So it may change. You cannot say 100%. Some patients who do not have complications, then we can start from 6 months.
At the
But
time, right.
whatever it is, the vaccines should be given only with the consultation of the treating physician. Yeah.
Exactly.
Yes.
Yeah.
Thank you.
And I just raised my hand and just again, Catherine and all the group, first for the vaccine, there is a very strict, we have a policy regarding the vaccination. Catherine, you are right. We start thinking of vaccination for autologous after 6 months, 1 year for the allo, and there is a very long protocol. Again, they have a guidelines, we have it. This is also we can prepare it for you guys and give it to you. It will be part of the material we are gonna put on the site here, because it is important. Amala, we send all the vaccination guidelines.
Thank you.
Okay.
Thank you, Regi.
Okay.
Okay. So there is a question
And
in the...
Carol, she's put online, you can see everyone. So of course we don't give a live vaccination. Remember this, Catherine, we have to send, to make it very strong, the guidelines. I have all the guidelines on the vaccination. So I will send it to you, to Catherine, and you can then work on it and send it to the group.
Sure.
Perfect.
Yeah, maybe you can share with all of us also, you can share.
No, of course, it's for all of you. It's not for me.
Thank you.
It will be shared with all of you,
Sure.
of course.
Thank you.
Yeah.
Okay.
Yeah,
There is one
thank
more
you.
question.
Yes.
Yes, there's one more question from the on-site participants. Yeah. Okay, so the question is, since GVHD is may or may not be a side effect post HSCT, is it advisable for the patient to have prophylactic corticosteroid, and what effects does it have on engraftment? Does it also help to prevent GVHD? Yeah, that's the question here.
I'm sorry, Blessing. Can you repeat the question? I lost the sound a little bit.
Okay, so the question is, it's like a multiple question in one. Okay, so since GVHD happens to be a side effect post-HSCC, which may or may not occur, is it advisable to place the patient on prophylactic corticosteroid? What effect does it have on engraftment and also in prevention of GVHD? And how can the patient be on that?
So usually we don't start patients on steroid as a prevention. We only give them when we see that graft versus host disease is occurring. That is because we want the new cells to engraft by themselves. If we place them on steroids before, we can accelerate the process, not on the natural way. I don't know if, so that is why we don't use steroids as a prevention. But we do give the patients, these days, there's a lot of patients receiving cyclophosphamide post-transplant to prevent graft versus host disease. And it's given after the infusion, usually day 3 or day 4. And also with the immune suppressive medication that the patient takes, that's how we can prevent it, but not with steroid as ahead of time.
Catherine, did you mean cyclophosphamide or cyclosporin?
Cyclophosphamide.
Okay.
Phosphomide after the transplant.
Okay. In the UK, we use cyclosporin as a prophylactic against graft versus host disease.
So here we used to use it, but now they're switching to tacrolimus.
Okay. Yeah. Yeah.
Yeah. Yeah, but we use, the usual one is cyclosporin. Yes, cyclosporin for all the patient, and we give we don't really, first things, the first hand is cyclosporin. But we have the two guidelines as well.
Right.
Can I just add? Generally, we start tacrolimus for patients who are having some renal impairment with the cyclosporin. So because cyclosporin will cause renal toxicity, so those patients, tacrolimus is the drug of choice.
That's right. That's right. It's yes.
Sometimes we have the tacrolimus, sometimes we have the cyclosporin. It depends on the type of
transplant.
Protocol.
Or the protocol. But the cyclophosphamide post is always for the aplidentical transplant. We have also the cyclophosphamide post.
I think there is one more question. What are the possible ways to prevent graft versus host disease?
I wish we have.
Right.
How to prevent.
So it's like what we were saying before with the immune suppressive medication, but unfortunately, sometimes that's not enough. This is something that can happen or cannot happen, but we do try with the immune suppressive medication mainly.
Yes.
Thank you. I just wanted to add, sometimes some amount of GVHD is important. It is good for the recipient, for them to develop the immune system. It is important for them. Only it should not go very severe, maybe like stage 4 and all, then it may become very difficult.
Right.
Thank you.
I know that doctors like patients to have that, especially in leukemias. So we can, we have to find the balance. That's the problem.
Yes. Thank you.
Thank you.
Yeah, thank you, Catherine. Thank you. Very good session we had. So we'll move on to the next session. So our next speaker will be giving us a supplemental topic on internal policies and procedures. It will be lectured to us by Eugenia Trigoso. As you well know, Eugenia is one of the energetic members of the WBMT Nurses Group Committee and has been giving lectures in our consecutive webinar sessions. Eugenia is the WBMT Nurses Group Committee Vice Chair and currently a JCE Inspector, an active member of different nursing groups in different societies related to oncology or BMT, such as European Society of Blood and Marrow Transplantation, among others. Again, thank you, Eugenia, for your generosity with your time and untiring support to this endeavor. Please kindly proceed with your topic. Over to Eugenia.
Good afternoon. My name is Eugenia Trigoso. I am clinical nurse and I am going to talk in this webinar about the internal policies and procedures. But internal policies and procedures were most important thing that is needed for bone marrow transplant, that is the central line. We need really a central line for all the bone marrow procedures. So we are going to talk not about the internal policy and procedure, but where we can find information, where we can learn about central line. Well, if we go to the European Blood and Marrow Transplantation textbook for nurses, in the chapter 5, they talk about the cell sources and apheresis. We know that a successful collection of cellular blood products via apheresis has its challenge and is influenced by a multitude of variables, including patient's clinical condition, of course, vascular access, timing of collection, mobilization regimes, institutional capacity, staff experience. Staff experience is one of the most important challenges that we have, and regulation and accreditation. In this chapter also they talk about the vascular access for apheresis. We know that a good venous access is essential to the success of a procedure, facilitating a good steady blood flow through the cell separator. Catheter used for apheresis procedure must be able to tolerate large fluctuation in circulating blood volume. But in the absence of adequate peripheral veins, a large bore dual lumen device can be inserted for apheresis, even if it is only for apheresis and after we can take out. This can be placed in the femoral vein or internal jugular by experienced practitioners. As we said in the slide before, the experienced practitioner is one of the most important topics of this issue, and may be inserted temporarily for collection only or placed and used after for the transplant period. And what more? What the Journal of Infusion Nursing said. So the Journal of Infusion Nursing talk about apheresis, and they say that the peripheral or central venous access device are recommended for therapeutic apheresis as follows. We need to use a 16 or 18 gauge peripheral catheters placed in antecubital veins for adults. But also we need a peripheral vein access is not recommended in young children, less than 30 kilos, due to the small veins, of course, but may be possible with older children and adolescents. We know nowadays adolescents sometimes are bigger than we are. We need peripheral veins are not appropriate for filter-based apheresis system. We need to use a non-tunneled or tunneled covered central venous access device with a catheter size of at least 1.5 French for adults. But also unimplanted vascular access ports are used less commonly. Peripheral inserted central catheter should not be used for therapeutic apheresis due to small internal diameters and inability to accommodate blood flow rates. But also sometimes arteriovenous fistula and some arteriovenous graft may be placed for long-term treatment. The Journal of Infusion Nursing, they have some standard of practice. They have quite a lot, but in the section 1, they talk about the infusion therapy practice. They talk about the patient care and the standard for patient care. They talk about the infusion therapy standard of practice is applicable to any patient care setting in which vascular access devices are placed and or managed and where infusion therapies are administered. They also talk in this session 1 about the infusion team. That is the most important thing during the bone marrow transplant period. In the standard 4.1, they say that the infusion team is structured through its scope of service to meet patient and organizational needs for safe, effective, and high-quality infusion therapy. In the practice criteria, they talk about the assigned vascular access device, insertion or vascular access device management and surveillance only to individuals and or teams with infusion therapy education, training, and validate competency. As we said before, the most important thing is to have a very well-trained team. And what JC said about this topic? Well, if we go to the standard JC, in the part B36.3, they talk about the clinical program shall have access to personnel who are trained and competent in cellular therapy product collection by apheresis and utilize an apheresis collection facility that meet these standards. And what they say about nurses. The clinical program shall have nurses formally trained and experienced in the management of patients receiving cellular therapy. Also, there shall be written standard operating procedure or guideline for nursing procedure, including but not limited to central venous access device. Well, and where we can learn about what is the best way for place the CVC or how to take care of, well, there are different organizations that they are focused in the management on central venous access. The group Avatar is focused about Avatar means Alliance for Vascular Access, Teaching and Research. Avatar, this group and this association is focusing teaching most of them the peripheral inserted catheter, and they are focused or their city special is they are in Australia, and they say that no patient or carrier wants to experience painful needle puncture to insert vascular access device, or for their device to become blocked, fall out, or to develop a serious infection or blood clot. At Avatar, we don't think these things should happen either. Their mission is to make vascular access complication history. Also working with them, we have the GlobalNet and the GAVI-CELT, and we have there the link for this website for information. The GAVI-CELT is a very good website for vascular access. They have a lot of courses, but most of them are in Italian, and some of them are in English too. And also we have the Cancer Nurses Society of Australia. They have a very good vascular access guideline. The Cancer Nurses Society of Australia, they have the vascular access device evidence-based clinical practice guideline that is sent in 2024, and they provide recommendation for clinical practice based on current evidence. This knowledge based alongside your clinical expertise, individual patient preference, products and their appropriate application. And they have also the link for the website for the guideline. And what more, they have the contents of this guideline is focusing collaboration and endorsement, terminology, patency occlusion, prevention and management, vessel health and preservation, device selection, and difficult intravenous access. And also they have the section 1 that is talking about education and competency, patency assessment, flushing and looking practice, catheter tip and peripheral inserted venous catheter position, confounding factor and patency. And in the section 2 is focused in the vessel health and preservation, device selection, patient with difficult intravenous access, etc. But what is also very important information is the central line associated bloodstream infection for the Indiana Department of Health. They have a very good guideline and they have a lot of slides about how to take care of the CVC. They have the link also is below. And the objective of this guideline is to identify signs and symptoms associated with central line associated bloodstream infection. They have to identify intervention to prevent central line associated bloodstream infection, implement care and management of central line catheter before, during, and after insertion, and identify the 4 recognized routes for contamination of catheters, identify the indication used for central line placement. All the presentation is not in, all the presentation from the Indiana groups is not in this presentation, but you can always go to the link and they have a very, very nice slides and presentation. Here we can see where to place the best site for placement of the catheters, and also there are different kinds of central lines. Here we can see one of 3 lumen catheters that is very useful for bone marrow transplant. And what more resource they are? Well, if we talk about the central line and clean and infection, they have the central line associated bloodstream infection. They have the guideline for intravascular catheter related infection, and also this other paper about the central line. They have that we talk about the continuing education and activity. The objective is to identify the indication for central line placement, to describe the recommendation of the recommended patient position during central line placement, review the complication associated with central line placement, and outline a structured interprofessional team approach to provide effective care and to appropriate surveillance of patients undergoing central line placement. And what more? We have also the guideline for the prevention of bloodstream infection and other infections associated with the use of intravascular catheter. That is the guideline for the WHO, and that is focused in peripheral catheter, but the part 2 that is going to be developed in 2024 is going soon, will cover centrally inserted intravascular catheter. They talk about aseptic no-touch techniques for peripheral intravenous catheter, also about the aseptic no-touch technique for peripheral insertor virus access, talking about good practice statement and recommendation for the prevention of bloodstream infection and other infections associated with the peripheral intravascular catheter. They have the recommendation and good practice statement. Here is the link for this guideline, and they talk about the healthcare-associated bloodstream infection associated with the central venous catheter are key concern. Many of these patients have complex, high-risk medical conditions that require CVC, like bone marrow transplant, and they are often managed in healthcare settings such as an intensive care unit, where local care protocols are generally common and many confounding factors are often present. Not everybody is well trained for the management of central venous catheter. And what happens if we talk about pediatric? They have also the guideline, the best practice guideline in the care and maintenance of pediatric central venous catheter, and is the central venous catheter promote vein preservation by avoiding repeated attempt and use of multiple peripheral veins and avoid the pain and associated anxiety of repeat venipuncture for young patients. Also, they talk about assessing patients for the appropriate device upon admission of early in their hospital courselet to improve patient outcome and is cost effective. Also, they talk about the CVC use in the pediatric population, include the PIC, peripheral inserted central catheter, the non-tunneled CVC, the tunneled CVC, implanted port, hemodialysis catheter, and apheresis catheter. And what more? They say about appropriate CVC selection should be based on the diagnosis, previous history of vascular access device, anatomical variants, and type of the length of therapy, along with the patient and or caregiver preference. And here we have a lot of reference for where we can find information on how to learn about to take care of our CVC and about to take care of our patient. Thanks, and open for your questions.
But all the webinars, they are already on our WBMT website. You can go and you can get them from there.
Gotcha.
So,
okay.
Yes.
Thank you. Thank you.
Yes. Thank you all. Thank you all.
So,
thank you.
Yeah.
Blessings.
And
yeah. We want to thank everyone for
the
today's presentation.
It was a great time. You know, it was a great and nice webinar. Very, very good. Thank you, Amala and Blessing, for handling and all the others, you know, to be there, and all of you, you know, the speaker, everybody. It was really very good.
Thank you to all the participants.
Thank you.
Also.
Thank you.
See you in the next one.
Thank you, Paola,
Thank
Catherine,
you.
and Eugenia.
See you in the next
Also, I
one.
thank WBMT for the opportunity for moderating the session, and the presentation. Wonderful, excellent, very, very informative session, Paola, as well as Catherine and Eugenia. Thank you. I hope the participants would have benefited. Thank you. Thank you, Blessing, for mediating the session.
Thank you,
Mom.
Thank you.
Bye.
Thank you.
so much.
Bye. Bye. Bye.
Bye. Bye.
See you all.